we're approaching a patient thinking about who requires mutational analysis, someone who has lost their response, meaning that they have progressed from a chronic phase to an accelerated phase or blast crisis, someone who's lost their hematologic response, or also in individuals who are following with every 3-month molecular studies, and we identify that they've had a log-fold increase in their BCR-ABL copy number. I think kind of all of us would agree that those are the clear indications of when to assess for mutational analysis. How do you go about ordering that test? And when you see specific mutations, how does that affect your choice of drug?
As far as what we do with the information, again, this is absolutely critical, and why it's critical to do the test is an enormous amount of work has gone into trying to identify particular best therapies for particular mutations. And so we know of all the kinase inhibitors, certainly imatinib has the most vulnerabilities for drug-resistant mutations, and ponatinib has the least. The second generation drugs are pretty comparable and having a relatively low number of vulnerabilities, but those vulnerabilities differ. And so I've had, on occasion, a patient referred where the clinician recognized the loss of response and did the right thing and ordered a mutation test, got the result, but unfortunately, didn't use that information to choose the appropriate next therapy and chose something that if she had read the guidelines, would have known that it was actually not going to be efficacious. So a wonderful resource is in it can be found in the NCCN in terms of which mutations are problematic for which of the kinase inhibitors. Similar data can be found, I believe, in the ELN guidelines as well. And there are, it should be mentioned that there is an approved therapy for CML, which is not a kinase inhibitor, omacitaxine, which since it doesn't work to the best of our knowledge through inhibiting the kinase activity of BCR-ABL, it is not, the mutation status may not necessarily factor into whether or not to choose that particular agent.
Yeah, one thing that I always like to remind referring physicians who see these mutations and want to act on them is that we have some good guides, but they're not a guarantee. You still have to follow that patient very, very carefully to ensure that they do respond to the agent you've picked, because a lot of what we know about the mutations and individual drug sensitivities has to do with is based on relatively small numbers of patients being tested and found with those mutations.
And to add to what you're saying, Doug, actually resistance is multifactorial. It's very simple to say it's only mutation driven and I switch a drug and that should work. We know sometimes based on a pivotal trial run, then we have a mutation sensitive to drug X and yet we don't see a response. So we should keep in mind the resistance is multifactorial.
Exactly.
But Jessica, as you were saying, these tests are available to the community. They're not academic university type tests. Almost every single commercial lab that does a PCR for BCR-ABL will have a box right underneath saying if you want the mutation test. So, and they're not that expensive, especially when you talk about if you're going to switch to an expensive second generation drug, picking the wrong one and spending thousands of dollars on the wrong drug when you could have ordered the right test easily in the community.
Right, and those mutational profiling studies tend to be covered by insurance.
Correct.
There has not, in my experience, I have not had an issue with coverage.
Yeah, and the test can be done on the peripheral blood, and it's basically equivalent to the PCR test in as much as the BCR-ABL signal is amplified and then it's subjected to sequencing. One thing to be aware of is if the level is extremely low, like if you have a patient who went from being undetectable to just barely being detectable, the odds are that when you subject that to amplification and sequencing, you may be more likely to pick up just an artifact. You have problems with the signal-to-noise ratio in those situations. So I don't recommend testing for someone who's been persistently molecular undetectable and now just has, the slightest low-level positivity. Obviously, if it's closer to the MMR threshold and loss of the MMR threshold, then that's obviously much more concerning.
And another thing about testing is that you want to do the test while the patient's still on the drug that's not working. I've had patients who have been sent to me, they stopped the drug because they got a bad result. Then I do the test later, a month later, or they've been off drug, and the wild type clone starts to grow and obscures the ability to be able to see the test. So once you see that the patient is not doing well, you can often call the lab and say, you just gave me a bad result on PCR, can you add that other test on? Because you'll get the test while they're on the drug that's not working, so you know which mutation is there.
Yeah, and I think that's a very important point, is that sometimes labs will save the PCR product that alarmed you into getting the mutation test. And so you can sometimes just call the lab and say, you have that PCR product, can you just do sequencing on it? It doesn't always work, but it may, save having to call the patient, have them come in for an additional blood draw and further delays.